Thank you to the organisers for asking me to speak on cognitive impairment in ageing, PLWH, and persons living with HIV disease. Importantly, this presentation was significantly contributed to by Lucette Ziek. Now to the overview. I'll talk in three sections: why the concern, what's the evidence, and what to do. Why the concern? There are some theoretical suspicions. PLWH are living longer with almost normal life expectancy. We know that age is the #1 risk factor for cognitive impairment, so it's an issue. Second, PLWH, despite effective CART, have persistent low-grade inflammation. Chronic inflammation is associated with and probably partly causes cognitive impairment. And there's an increasing burden of comorbidities, especially vascular. Cognitive impairment is associated with vascular risk factors. Now, age-related neurodegenerative diseases has a number of steps involved. And each of these steps, almost all of them, are associated with HIV and with age, as well as comorbidities, as well as antiretrovirals. So you can see patients and persons living with HIV have a 4-hit, if you like, to the steps involved in age-related degenerative diseases in the nervous system. Additionally, comorbidity burden in patients and persons living with HIV increases significantly with age, best shown here by a publication from a few years ago. And you can see those who are age 70 and above, almost half of them have more than 3 comorbidities. Same data from a Canadian study, and here 71% of those over 70 have 4 or more comorbidities, a very significant burden. There are more reasons for theoretical concern apart from the CART neurotoxicity over the long term. There's a potential for drug-drug interactions, a direct consequence of the increasing pill burden, and again, a direct consequence of increasing comorbidities. There are 2 concepts slides that I want to really emphasize to help provide a roadmap, I think, for further studies in this area. Now, these concepts are not just pedantry. They have wider significance for further research and intervention, and importantly, they're not exclusionary. Now, premature aging occurs clearly before the usual age-related decline in cognition, but that means if it happens, earlier services will be needed. Second, accentuated aging is greater severity of cognitive decline, and that means more services are needed. Third, accelerated aging means greater progression of cognitive decline. That can only be assessed by longitudinal studies, but it means that more services will be needed with faster implementation. This is just a cartoon to show that if you look at prevalence of cognitive impairment, 50% by age 85 of the normal population will have cognitive impairment. With the start time around 65, you won't be able to see a real difference with any confidence between normal and accentuated aging if you're just going by prevalence. Clearly, you'll be able to see some signal for premature and accelerated aging. But importantly, if you look at severity of cognitive impairment, you will be able to tease this apart. But I stress that these are cartoon representations of the concepts, and clearly there may be some populations which will have a premature accelerated or a premature accentuated course. The other slide in terms of concepts that is important to drive home, I think, is the age duration effect. That is the age of the patient with the duration of HIV disease. You shouldn't take one without the other. So the 35-year-old with 10 years of HIV is not the same as a 75-year-old with 10 years of HIV. The suppression duration effect is the time of viral suppression. In this day and age with CART, that usually amounts to years. But it's important because switching off viral replication means toning down the inflammatory response, and that chronic inflammation, therefore, if it's down-regulated, means less of a risk for cognitive impairment. And then you should put these together, the age suppression duration effect. Then to use the same example, 35-year-old with 10 years of HIV with 10 years of suppression is not the same as a 75-year-old with 10 years of HIV and 1 year of suppression. So what's the evidence? We've got real-world data and observational studies. So the real-world data, we already know from earlier studies that in the US that residential care is going up in PLWH. And in those residential care facilities, there is a significant burden, a higher burden of patients who are HIV positive with dementia. This is borne out again by the South African study showing that from age 60 onwards, the HIV positive population carries a higher burden of dementia. Now, what are the observational studies? So Aung pulled all these together and came up with the following conclusions. So most studies had a low sample size and were cross-sectional. The tools for neuropsych evaluation were not homogeneous. 14 of 36 did not have HIV negative controls. Over 60 population proportion was still low. Studies that were longitudinal, however, had a high sample size and had a high proportion of older participants tended to find this interaction between HIV and age and cognitive impairment, and other factors such as nadir, CD4 disease stage and duration seem to be important. Now, when we go into the granular detail, these messages, I think, are going to be very important to aid in design of future studies. So the small sample size is a common problem. You have to realize that for 80% power, to give a small to medium size effect, you need 350 participants for premature aging, 1,050 for accentuated aging, and 230 for accelerated aging. You must really have HIV negative controls. You should try and minimize clinical heterogeneity and you try and get patients who are at least over 50. Try and avoid ascertainment bias towards historical aids and non-community samples, and try and get a reasonable follow-up time. The longest follow-up in these studies has been 4.7 years, not really adequate. Try and include an age duration effect. This was hardly ever accommodated in the studies we looked at, and in fact the disease duration was often less than 12 years. The suppression duration effect was not included, let alone the age duration suppression effect. The evidence for premature decline, 20 studies, only 3 were longitudinal. 9 of these 20s were positive and only 1 longitudinal. The evidence for accentuated decline, 2 studies, both negative. In our own study for accelerated decline, we matched what 3 of the 4 longitudinal studies had found, and that is a signal for accelerated cognitive decline. We merged a US data set with our own and found a number of signals for increased risk of cognitive decline as we age. And the risk is, as you can see here, an odds ratio of 1.92 if you're over 50, and comorbidity excess as well as renal impairment and previous stroke. So it is possible to get these numbers up if you merge data sets. So with that then, what to do? Well, I would direct you to session 4, delivery of care of the elderly in PLWH. And I think targeted screening should be offered to those who are 50 years of age and over, especially those with comorbidities that are associated with increased risk, which we've detailed previously. Now, which screen? This is controversial, but I think it should be stepped and it should be clinical to begin with. Simple questions with validation from an informant, patient's loved one, colleague, and then something simple at the bedside, such as a MOCA test or the HIV dementia scale, although you must use a liberal cutoff for the HTS. And then where resources permit, more formal neuropsych testing. Now, a number of people contributed to this, particularly Lucette, Sazik and Tain Aung, but others listed here have all been very helpful in pulling these data together. Thank you.